Next talk, Dr. Vivek Vij is here now. So he will be basically presenting a video on lap liver resection stepwise approach. Vivek.
Good morning and thank you very much Sanjay and whole IASG organizing committee for this invitation. So today the task given to me is to present on liver resection step-by-step approach. So as we all know that, we can stop it just for a minute. As we all know that any liver resection has three major components. One is inflow control, second is outflow control, and third is parenchymal transaction. And these have to be done in such a manner that it produces minimum post-operative complications. So today I'm going to present to you a laparoscopic donor hepatectomy with the approach that we control the porta first, outflow first, clear the cava, and then do parenchymal transaction and then take out the liver. So this was a case of a young donor who was donating to father, and right lobe was about 700 cc's or 700 grams. And in laparoscopic donor hepatectomy, we usually place 5 ports for right lobe, and we usually place 4 ports for left lateral or left hepatectomy. And the first step is, of course, to free the right lobe of liver from the attachments. We divide the falciform ligament, right coronary ligaments, right triangular ligaments. And this is you can see these veins. These are diaphragmatic veins, which are very good marker of where the confluence of right hepatic vein goes to IVC. And slowly we completely mobilize the right lobe of the liver. Sometimes when the liver lobe is very heavy, it's difficult to retract the lobe towards left side. But there are techniques. You should make the gallbladder as handle and then retract the liver rather than directly lifting the 1 kg liver or 800 grams liver. That becomes very difficult. And the injury caused is also very less if we make the gallbladder as a handle to manipulate the liver down, up, right or left side. So these are right lobe mobilization, right coronary and triangular ligament being taken down. Now we have completely freed the right lobe of the liver, and this is the IVC. We can see we can burn the small veins with the thunderbeat or harmonic coagulation, and the bigger veins we have to either clip them or staple them. So it's very important that whole team is trained to manipulate the liver. Whole team is trained to knows where to retract and when to retract, because these are very sensitive areas. So we use whole of the dissection is just like open liver resection. We use fine instruments, and this is where we are making a plane of between the middle and right hepatic vein. So what I am using is a gold finger. Now this is no more available, so we don't use gold finger now. We completely free the cava and directly put the Ryle's tube for the hanging maneuver. So there were many replacements for gold finger, but I think that gold finger was till date the best one, because it was made of plastic, very lightweight, very easy to maneuver. So we pass the Ryle's tube for hanging maneuver and take the tip out from suprahepatic cava between right and middle hepatic vein. Then we divert our attention to porta hepatis and divide the cystic artery. Now, there's a difference between when we do donor hepatectomy and hepatectomy for tumors or benign diseases, because in tumor and benign diseases we can just divide and we don't bother about maintaining the lengths of vessels as well as anything else. But in donor hepatectomy, it's a preservative surgery, so we preserve the lens with some logic and protocols. So this is, we are trying to loop the right portal vein on the right side. I routinely use these debakis, which are very fine debakis. I think they have changed the way we do laparoscopic dissection. After looping the right portal vein and right artery, we mark the ischemic line. And superficial parenchyma about 1 centimeter we can divide with harmonic scalpel or thunderbeat. My personal preference is thunderbeat, but harmonic is equally good. So this is one of our initial cases. Now the parenchymal transaction is very fast. We do it in around maybe 30 to 40 minutes. You have to be as meticulous as in open donor hepatectomy or open surgery. And this is the segment 5 vein which was retrieved. We always double clip on remnant side and then slowly move towards completion of transaction. We routinely use CUSA for transaction, and there are various kinds of CUSAs available. The best is the CUSA with which you are comfortable. And then going towards segment 8, we can see that there is a segment 8 vein which we can loop and divide. So this is the right hepatic duct. There are various ways to divide right hepatic duct. In laparoscopic surgery, there are 3 ways. Either you can loop it first, then divide it. You can divide it first, then clip it. Or you can divide it and just suture it. After division of the right hepatic duct, this is the hilar plate. And we clip the hilar plate with the Hemolox OMAS. So we have just completed 150 cases of pure laparoscopic donor hepatectomy, and in last about 80 cases there is no bile leak because we have become more meticulous and more experienced in dealing with these things. So this is the last part where we divide the parenchyma over the Ryle's tube, and this is again a kind of instrument like Goldfinger, which is called as Pinky, which many bariatric surgeons also use. And this is the right hepatic artery. We loop the right hepatic artery, bag the liver. These are big bags which are available for even 1 kg or more than 1 kg liver. We double clip the right hepatic artery. So in a normal liver resection for tumor and all, we just need not worry about the length of vessels. We use staplers. These are IASGCON staplers, vascular staplers, which are called as echelon flex, and they can be maneuvered. This is the right hepatic vein, which is transected and divided now. Initially, we used to leave this hepatocaval ligament to be divided later, but now we divide this hepatocaval ligament at initial stage. This has drastically decreased our warm ischemia time for right lobe retrieval, and we take it out from the fan and steel incision. And it's about 10 to 12 centimeter fan and steel incision. I think that's what I wanted to show you. Thank you very much.
Oh, that's one very nice video. So I think all of us have seen laparoscopic now, the donor hepatectomy. We have not seen much of laparoscopic hepatectomy because of the diseases like CRLM or HCC or things like that. So do you have any extra take on that? Because
yes.
there have been a lot of
yes, of
lot
course.
of work has happened on
yes.
that.
Although we don't do too many cases, but we routinely do about 5 to 6 cases of hepatectomies for laparoscopic hepatectomy for other diseases. Now, in those diseases, of course, there are certain other things like Gleasonian approach. which we do for some parenchymal transactions or some resections. And obviously, with laparoscopy, we routinely use ICG also, either positive or negative ICG.
So, as far as this Glisonian approach,
Yeah.
suppose in a major right appendectomy or left,
Yeah.
Do you use almost routinely in laparoscopic cases, or you do
I
otherwise?
use routinely for resections which are not donor resections.
Okay.
Yeah.
So, but
And it's very easy procedure.
there are situations where you won't be able to find out the LENEC in maybe chemotherapy, post-chemotherapy.
Of course,
so
then
in
of
those
course we have
situations
to
you
resort
go
to
for
other
it, yeah.
methods. But as far as possible, if we can use it, we should do Glisonian approach. Of course, tumor should not be near to porta, to the Glisonian pedicle, and all those things do apply. But if you can do it, you should do it. I think it makes the resection very easy.
And more comments on laparoscopic pure liver resections or donor. Dr. Anil also was there. I think the 2004 he invited Dr. Daniel Charkey. Do you have something to say, Dr. Anil Agarwal? Because laparoscopic liver resection has really has come a long way, and it's now, there are a lot many consensus and other things which has come almost a standard of care, but we don't do much on that.
Thank you, Arindom, and I think very nice to see these presentations, and it's very heartening to see that I think 2004 that you talked about when Daniel had come, and at that time I knew so he was at conference of IAS, and he had a presentation because he had done the lab over hepatectomy and also the lab level resections, and I think that showed that how we should proceed, and that is the way to go. And I think one of the comments that I remember what he said during that panel discussion was that I am a liver surgeon, not a laparoscopy surgeon. And it is so heartening the way this field has developed in our country is that unlike some of the other procedures which were probably left to the so-called general laparoscopic surgeons, I think it is very heartening to see that the HPP procedures have been taken forward by all the GI and the HPP surgeons. It is very, very heartening, and now there are so many centers which have got more than 100 lab or robotic donor hepatectomy. So this is the way to go, and very heartening to see this progress from 2004 to the last year.
Yeah.
So have you arrived yet to go for laparoscopic liver resections in the posterior segments or in difficult cirrhotic beds and other things? Though I know that the cases are not that common, but we have very good people here who do this.
Posterior sectionectomy, if I may say that, because we did a couple of posterior sectionectomy, and one was for the limited Carol's kind of disease in the posterior segment. So in that, what we did was that we stapled in the end. I think we went towards the margin and got the posterior pedicle and took it intrahepatic and resected that. So I think now, as he talked about in the Glisonian approach, you can virtually go to any of the
Yes.
segments or any of the sectors, so to say.
Have any comment on that? On
Yeah.
HCCs or CRLMs in difficult segments?
So if you are trying to remove posterior sector or left lateral, then it's easy, because pedicles can be, Glisonian approach can be used outside only. But for monosegmentectomies, you need
No,
certain.
I'm not exactly talking about an anatomical monosegmentectomies, maybe parenchymals, sparing
Even
surgeries
parenchymal
in...
resection, see, when we go for laparoscopy and a monosegmentectomy, so the perception of depth has to be there. The ICG has come really well in that, in marking, in positively or negatively marking. We can give ICG 2 weeks before resection, or we can give inside the operation theater by positive or negative technique. So once we have ICG marking of the tumor, then creating a good margin even without segmental hepatectomy is more precise. I would rather adopt ICG for this monosegmentectomy with a proper margin rather than doing just blindly.
Do you think robot will be better in laparoscopic or robotic liver resection?
Robot definitely has its own advantages. So degrees of freedom, you know, you can manipulate, you can suture, but it has disadvantages also. The two big disadvantages are there is no tactile or other feedback, and secondly there is no CUSA. So you have to learn your way of transecting the parenchyma either by fracturing or just by CUSA or other devices. Not CUSA, by harmonic.
Okay. Yes, please, Dr. Pamicha.
Yeah. Hi, Vivek.
Hi.
Can you hear me?
Yeah, we can.
Nice, actually, very nice video. I just, because you said Gleasonian approach, and I thought maybe just to get a clarity on that. I think Gleasonian approach is bit, it's very blunt, actually, honestly. At current era of liver resection, you should be actually dissecting all the arteries and vessels extrahepatically, properly, and especially the bile duct. So if you try and sling everything together, and then there is a tendency people try and put a stapler there, then you actually land up with troubles. So it is better actually to do extrahepatic dissection if you are doing proper anatomical dissection, then, and especially about the bile duct, if you want to prevent your bile duct approach. So if you learn from the donor hepatectomies, because we do that meticulous way, that's why we don't get complication. So same approach should be applied to when you're doing for benign and malignant disease, rather than actually doing a blunt dissection and doing a Gleasonian approach. So that's my take on safe liver resection.
I would say Gleasonian approach is not a blunt dissection. We should learn it. It's a very good technique. So in my experience, it works very well. We actually have to be well versed with from where to loop, where not to loop. So it's not difficult at all.
Because I've seen both the sides of the coin. I've seen people doing that as well.
Maybe it's your personal experience. I agree with that.
You land up with lots of biliary issues.
Yeah, maybe it's your personal experience.
You land up with
maybe in
lots of
future
biliary
we also change. So till now our experience is okay.
Yeah, Dr. Srikanth.
Two quick comments.
Introduce yourself, please.
Srikanth from Bangalore. I don't have experience in robotic, and we used to do open, we do open and lap.
Okay.
We have no experience with superior segments, which is 7 and 8.
Right.
But left lateral, right hepatectomy, left hepatectomy, posterior sectionectomy. So I would say overall we have done 112 resections.
Fantastic.
Posterior sector 11. So when Pamecha was saying about this not being a good approach, I think Gleasonian would be a great approach for laparoscopic actually, or a minimally invasive. In open, you do it that way. I think if you can learn and do this is a better. As in the last decade or so, we've been dissecting and doing, as he has been saying. I want to learn this for posterior sector, for example.
Right.
So we would dissect the vessels, go to the branches, sloop them. It's tedious. If you can learn this technique, I think it's swifter. You can put a bulldog, you can make your sector is okay, and then only staple. You don't blindly staple.
Yes.
Well, any comments from the floor? Sir, please.
Ramesh.
Sir.
Yeah.
Vivek, nice presentation.
Thank you, sir.
I just want to say that I'm completely with you that the Gleasonian approach is the way to go. It actually allows you a lot of leeway as far as altered anatomy. It keeps the vascularity of the bile duct intact. It allows you so much facility in movement that I think it's something that we are not quite used to. At least surgeons don't embrace it nearly as much as they should. Bernard Lonwa's technique is fantastic, and I think Srikanth emphasized it, that we should be teaching that on a large scale to everyone. As a start, you can do a Gleasonian approach, and then open the Gleasonian sheath to do wherever you want to transect, whatever you want to transect. But you must start by, getting the pedicle.
Right, sir.
Great. Any more comments? Is Dr. Tyagarajan there? Robotic. You have a comment about the robotic advantages on laparoscopic? I'm sure you said that you were And please have some, we have some few minutes, 3-4 minutes if you can just finish off.
So the thing with robotic is the suturing is easy and you have inbuilt ICG. The learning curve is little less steeper than the laparoscopic. But I feel first you have to be a liver surgeon, then you have to be a donor surgeon. Then both of these techniques can be safely learnt.
I'm asking you for some disease like CRLM or HCC where you will be venturing. I understand about the transplant, but in other situations.
Other situations, robotic resections you can do robotic ALBs, you can do robotic ICG based segment 7 resections. Anything which can be done in laparoscopy can be very well done in robotics as well.
I think robotic and lap are
Complementary.
just techniques. You know, the principles of liver surgery don't change, whether it is donor resection or CRM or HCC. I think we have to follow the similar principles as for open surgery, and we have to learn driving these techniques. These are just cars. We learn to drive. You know, that's it.
And similarly, regarding the Gleasonian, what I want to add is, no single technique is better than the other. Gleasonian has its own place, open dissection has its own place. They are complementary to each other. You cannot say that one is better than the other.
Yes, of course. We have to know both the techniques.
Yeah.
Gleasonian is a bit faster. You know, if you know it properly, then it's easier to do.
So if there are no more questions or no more comments, so thank you, Vivek.
Thank you very much,
nice
sir.
stepwise resection presentation.